Okay, so good morning, everyone. Welcome to the Lurie Cancer Virtual Grand Rounds. Now, month 3 of COVID, but hopefully we'll be returning face-to-face soon. Before I introduce our speaker today, you'll see in the chat area that you can find the activity code that's usually present in the room, 56774, and then the phone number to get credit for participating. I should also say that as we go through the talk, if you have questions that you want to pose, please put them in the chat function so that we can collate them and then have them available at the end of the talk. And finally, for those of you who are in the division, there is a division meeting immediately after this. So without further ado, I'd like to introduce today's speaker, someone that's well known and loved by everybody on the faculty at Northwestern, Hau Kwaan. Hau has been a member of the faculty for decades now and has been a prolific investigator over that time, a loved educator of generations of faculty and trainees. And he has stayed relevant in everything he did all the way to the present time, because his talk today is going to touch on COVID-19. And I know personally, he's written at least 2 papers regarding fibrinolysis and COVID-19 in the last month. For all I know, he's done more since then. And he has a couple of projects ongoing with other collaborators at the institution, looking at how coagulation touches on the COVID-19 pandemic. So Hau, please take it away. We look forward to your talk.
Thank you, Bill, for the nice introduction. I have nothing to declare. So the objectives of today's talk will be recognizing the hypercoagulable state in COVID-19. Then second, to know the thrombotic complications, such as VTE, PE, and so on. And third, to find the best fit hypothesis on the mechanism of this hypercoagulable state. And finally, discussion how to handle it and discuss the different guidelines, different organizations that put forth for this. So before I start, here's a timeline of the disease. And with the onset, patient progress on to getting more sick. And then finally, they are either recovered or they died. And the reason I put this out first is that whenever you discuss the coagulation changes, we have to note that whether we're dealing with the early phase of disease or when the disease gets very severe, the patient's ICU or ventilated, and then finally at the time of recovery. So with that introduction of the timeline, I would like to start with telling you what are the coagulation profile like in the COVID-19. Starting up on the top with the pro-time, or either the ratio INR and then the PTT are usually normal. But then the PTT can be prolonged, and sorry about that. And the prolongation may be due to the presence of a lupus anticoagulant. So more about that later. Secondly, you can see fibrinogen is mostly normal, but when the patient has severe disease, it's high, in fact, exceedingly high. And the level has prognostic value. The other notable abnormality in COVID-19 is the high D-dimer, and I said very high, up to sometimes over 10 times the normal upper limit. And again, the level has prognostic value. Factor 8 is normal. The next factor is factor 12, and usually low. People usually don't measure, but in this disease it's low. More about that later, why that is so. Von Willebrand factor, usually normal. And then the anticoagulant factors, antithrombin, protein CNS, usually normal. Platelet count can be normal and low. If it's low, it's seen usually in severe cases. It will have a poor prognostic sign. We're not sure if the platelets functional or partially functional. And then another criteria we use is the TEG shown on the bottom here. I'll come back to that. And then the other markers for acute inflammation, the CRP or the ferritin is frequently very high. And the height of this, again, has prognostic value. So my next slide shows just to introduce you to the TEG, which is basically a picture where you have a probe put into the cuvette with whole blood of the patient. And that cuvette is rotating. So when the clot is formed, you will see a picture like that, because there will be, with the clotting, there's a probe. We will have a torsion. The torsion is recorded in these pictures. Now, if you were to look at the ROTAM, which is the machine we use in our hospital, instead of the cuvette rotating is the probe. So it's the same thing, the probe is rotating. So here is on the right side, you can see two pictures. One picture is a normal showing let's see here, I might get my pointer, showing as the clot is formed, there's the amplitude increases of the torsion on the probe. But as the clot starts lysing, you will be seeing a narrowing of that amplitude. In a hypercoagulable, as shown in here, you can see it's a wider amplitude. So I have to show you an actual case. And here's an actual case with COVID-19 in our hospital. And here show the curve here. And please note that what we look for here is the amplitude at different times. A10 is 10 minutes, A20 is 20 minutes, and the amplitude is 74 and 78 millimeter respectively. And note that the upper limit shown on the right side is 64 and 70. So this patient definitely had a wider amplitude indicating hypercoagulability. Now we also look for the lysis, that's fibrinolysis at 130 minutes, 160 minutes. They are within normal limits. A few 3% down the lysis in the 60 minutes is still within normal limits. So this particular patient has high amplitude. That means the very strong clot and had no fibrinolysis. Now, the amplitude is a function of the fibrinogen, which we know is high, as well as the platelet contribution, the platelet function to the clot formation. You can separate the two by taking away the platelet function using the FibTam here, and you can see it's much smaller. However, if you look at those numbers at 20 minutes, it's 38 millimeter. It still way exceeds the upper limit on the right of 24. And again, this one can also measure lysis, and there's no fibrinolysis. So what is unusual in our COVID patients, other than that abnormal TEG or ROTAM I show you, is that there's a high D dimer and high fibrinogen. The platelet count is usually normal, but when it's low, it's not bad. It's not a good sign. Function is not clear. It must varies from patient to patient. But in a severe ICU patient, sick patient, they have severe coagulopathy, resulting in a number of publications saying there's a DIC-like picture. This is not the classic DIC. This is like a very severe coagulopathy. This is, there are many characteristics of this picture that is different from the classic DIC you see, say, in sepsis. So one of the problems is people try to use the ISC scoring to make the diagnosis of the DIC. And you can see that these are the problems. We have a high D dimer you can't use. You have a very high fibrinogen you can't use, and the platelet count is so frequently normal. So with that, it's difficult to use the IST score to determine the coagulopathy to be DIC or not. So more importantly, is what is so striking is the very high D dimer level. So I will just take 1 minute briefly to talk about D dimer. The D dimer is formed from fibrinogen. And when fibrinogen is clotted by thrombin, it forms fibrin monomer. And the fibrin monomer is further cross-linked by activated 13. And this cross-linked monomer is then cleaved by plasmin into different fragments, so-called FDP or fibrin degradation products. And these different products, out of these, there is one that is of interest, and that is a D and E. That is further split. The E is separated out, and the D is dimerized. And here's the D dimer. So in order to have produce a high D dimer, on the right side, you can see we will need fibrinogen, and fibrinogen in COVID-19 with acute infection, the liver synthesis of fibrinogen is greatly increased. We need thrombin. There's always some clotting in the body in COVID-19, and we need fibrinolytic activity. We need plasmin to split it. And finally, the D dimer is cleared from the body by the kidney. So if there's an AKI or acute renal impairment, the elimination of D dimer from the circulation is impaired. So it accumulates a higher D dimer level. So what is it like the source? Where does it come from in COVID-19 patient? Obviously, the main lesion is in the lung, in the alveoli, with diffuse alveolar damage all the way to ARDS. And there you have fibrin formation, hyaline membrane formation, and they are being broken down into D dimers. It can also derive in the COVID patient if they have thrombotic lesions as shown here, stroke, myocardial infarction, PE, and so on. I mentioned already the liver will make more fibrinogen, pour more fuel into the fire, so you're at high level. And I already mentioned the poor renal clearance in many patients. So then we have to turn to the other abnormalities, the unusual features rather. That is the prolonged PTT. Why is it prolonged? And much of this is due to the presence of a lupus anticoagulant. Just a second on what is lupus anticoagulant. Is a antiphospholipid antibody that blocks the phospholipid component when you perform the PTT test. And in some series published on COVID-19 patients, many of the patients has lupus anticoagulant. In fact, the term is a kind of a misnomer because at first it was seen in lupus patients with this antiphospholipid antibody, and it prolongs the PTT, so it's thought to be an anticoagulant. But in fact, if patients at this antiphospholipid antibody, it is more procoagulant. The presence of a high level of lupus anticoagulant makes the patient prothrombotic, highly prothrombotic, like in COVID-19, that's the case. And the next thing is the patient has a low factor 12. Now, you probably haven't heard of factor 12 for a long time because we don't measure it. Here, factor 12 involves, if you look at the familiar coagulation cascade, most of the time we look at the left side, the extrinsic pathway, which means when tissues and endothelium is injured, the cascade starts. But in COVID-19, we're talking of the other pathway, the intrinsic pathway. And the intrinsic pathway starts with the activation of factor 12. And so how does it start? Well, factor 12 is activated by the injured endothelium. Normal endothelium is a non-wettable smooth surface. So with blood in contact with it, it doesn't get started, the coagulation or so-called contact pathway doesn't start. But in here, because the endothelium has been damaged by the virus. Secondly, the platelets is activated again in COVID-19, and the activated platelets will release the dense granules which contains polyphosphate that can activate factor 12. And then we have the acute inflammation, the pre-kallikrein system. And at the same time, it's been noted people investigating ARDS shows that in the bronchoalveolar lavage fluid, there's a high factor 12 level. So factor 12 is being consumed at a pretty high rate. At the same time, there's also pro-inflammation after the kallikrein pathway forming kallikrein. So back to the factor 12, because of this, there's a tremendous consumption of the factor 12. And so that explains why factor 12 level is low. Now, why do I emphasize this particular phenomenon seen in COVID-19? It's because factor 12, even though it starts a coagulation pathway, paradoxically, say patients who are congenitally, who has hereditary factor 12 deficiency are actually prothrombotic. The factor 12 is first named after Mr. Hagemann by Dr. Oscar Rednoff. And many of you know that Mr. Hagemann died of massive pulmonary embolism. So it's a paradoxical fact, a low factor 12 is prothrombotic. Hypercoagulable. Okay, so we should now look into the thrombotic complications in COVID-19. What is unusual is there's a higher percentage of pulmonary embolism than usual. And obviously, this is related to the severe lesions in the lung. But at the same time, could be in the same patient, there's arterial thrombosis. And this thrombosis occurs in arteries that may not be previously damaged or diseased by atherosclerosis. You will see patients, young patients, with large vessel stroke. And then if it occurs in the veins and VTE and pulmonary embolism as well, it's in a severe patient. This is the early Chinese series of 81 patients. And here, VTE occurs up to a quarter of these patients. And they have prognosis because in these patients, they have 40% mortality. Another series from Holland by Middlethorpe shows that the difference between the sick patients, ICU patients, and the patient not sick enough to go to ICU. You see a big difference in the venous thrombosis rate. And then if you were to look at the, sorry about that, pulmonary embolism rate, you're seeing 15%, which is pretty high in the ICU patients compared to the ward patients. And it's still 2%. In addition to all that, we are seeing thrombosis present in catheters, in dialysis filters, in hemodialysis patients. More than 90% those fistulas are obstructed. And then in patients that needs extracorporeal membrane oxygenator to help to support them, the ECMO is frequently thrombosed as well. The other unusual feature is that the risk for thrombosis may remain weeks or months. We don't know really how long, even after recovery of the patient. I have colleagues telling me patients went home, then come back with PE, with pulmonary embolism. So this is not unusual to be seen in COVID-19. This is just a visual picture of the Dutch series, again, that I mentioned. You can see with time over 20 days, you can see the ICU patients and had VTE in as much as 60%. In contrast, it's much less, even in the ward patient of 9.2%. One more series, again from Holland and Netherlands, but a different group of patients. And here we're dealing with patients, all of them had been on low molecular weight heparin, and 41% of these patients had thrombotic complications. And these complications are pulmonary embolism, shown in here, other VTE, and arterial thrombosis as well. And again, plotted below, the graph shows with time, progressively increase over 20 days. Just to confirm this, I would like to look at another series, one more, and that is from France with ICU patients. All these patients are on low molecular weight thromboprophylaxis, and you can see close to 21% pulmonary embolism and only 13% DVT in these ICU patients. So now I think you get a pretty good idea of the unusual thrombosis seen in COVID-19. They had some significance early on. This is a very early series from China, from Wuhan, showing the presence of thrombosis has something to do, a very severe effect on a 28-day mortality rate. This is just comparing patients who is on prophylactic dose of heparin in blue color and those patients who are not on heparin. Of course, you may wonder why heparin is not given, because this is from China, and the thromboprophylaxis for ICU patients is generally not done because it's thrombosis is not as common as in Western countries. So here, different patients, different groups, the bottom showing the score, SIC score, when, and then on the right side is the D-dimer level. So you can see the red bars have a higher mortality than the blue bars. So, so with that, how much heparin should you be giving? There are many investigators and many healthcare takers seeing sick patients, ICU patients, are in favor using therapeutic dose of heparin in the ICU patients. And obviously they had to be, if they previously had indications of therapeutic anticoagulation, such as atrial fibrillation, they should be continue on that. Then in severe COVID patients, and I would like to bring up the role of a high fibrinogen. We see high fibrinogen in patients so-called with quote unquote heparin resistance. So if you're giving prophy dose of heparin with a high fibrinogen, you may not be able to get the desired therapeutic effects. Now, for people who is a little bit afraid, you give therapeutic dose, you increase the thrombotic risk, particularly patient who might be having ischemic stroke. You may, there is a potential of converting that into hemorrhagic stroke. So they would recommend quote unquote intermediate doses. This group definitely is in favor of treatment dose. This is a recent data from New York by a very respectable group, Dr. Fuster's group, showing all patients with the survival rate with and without therapeutic dose of heparin in pretty large number of patients. But those patients on the right-hand side, you see are the patients that require mechanical ventilation. The gap of the survival is much bigger. So from now I have to turn on to look, what is the mechanism of all that? And one of the most important explanation of all the pathogenicity of COVID-19 is through the recognition of the perturbation of the renin-angiotensin-aldosterone system. In this system, we had angiotensinogen being converted by renin into angiotensin 1. It's further converted by angiotensin converting enzyme, or ACE, into angiotensin II. Angiotensin II in a physiologic state will regulate the vascular tone, blood pressure, etc. But that angiotensin II is further converted by another converting enzyme, angiotensin converting enzyme 2. So ACE2 will keep the level of angiotensin 2 in check. It wouldn't be excessive because it breaks it down any excess into two other peptides, angiotensin 1 to 7 and angiotensin 1 to 9. Now, what happened is when the patient get infected with SARS, with a SARS-CoV virus, it will bind to angiotensin 2, ACE2. ACE2, and it's, the binding is by the spike protein on the virus. Now, ACE2 is abundant in the lung as well as in many other organs, including more importantly, in the endothelium. In the lung, it's abundant in the type 2 alveolar cells. So these cells are, contain ACE2 and it attracts the spike protein of the virus. The virus, through this binding, will gain entry into the cell and then replicate within the cell and damage the cell. So as a result of this, the ACE2 is used up, consumed, and is diminished in amount. And a lowered ACE2 level will allow the angiotensin 2 to build up. So we have a high angiotensin 2 as a result. The high angiotensin 2 is harmful to the body. First of all, angiotensin 2 will increase the Pi1 level. Pi1 is the plasminogen activator in the inhibitor 1, which is the main inhibitor of the fibrinolytic mechanism. So there's decrease in fibrinolysis, increase the hypercoagulable state. But I said high level angiotensin 2 is also harmful because it binds to a receptor in the lung. It causes acute lung injury and acute inflammation, but both of these lead to hypercoagulable state. The angiotensin 1-9, the other product, also can activate platelets, and the activated platelets also contribute to the hypercoagulable state. So I must say a few words on the role of fibrinolysis in the pathogenesis of all the hypercoagulable state in COVID-19 infection. In a healthy person, fibrinolysis is balanced between one side, left side, and the right side, but it's tilted. It's imbalanced in this case. So on the left-hand side, you have urokinase, you have TPA, you have plasminogen and plasmin. And on the other side, you inhibit fibrinolysis, which is Pi1 antiplasmin, and several other ones. So if there's too much plasmin, there's hyperfibrinolysis. Now in COVID-19, that could mean intra-alveolar hemorrhage. Although we observe very little generalized hemorrhage, but in many autopsies of a lung, you see in the alveolar area, there is bleeding. One other less noticed function of plasmin is the cleavage of the S protein of the virus, and that increased the binding of the virus into the ACE2 expressed cells. One other one at the bottom is plasmin also can impair the innate immunity of the patient. On the right-hand side, if it's, the Pi1 is strong, high, it would help favor fibrin deposition, which is the hyaline membrane in the alveolar. It would also cause microvascular thrombosis. And at the same time, it can also enhance the epithelial mesenchymal transition into fibrosis in the lung. So all these are happening in COVID-19. We still do not know at this time the long-term sequelae, whether there's lung fibrosis at this time. So let's look in COVID-19, and the same picture can be seen in SARS and in MERS. There's acute inflammation and release of inflammatory cytokines, and these will cause increase in PI1 and decrease in UPA and UPA. At the same time, the virus can also damage, as I mentioned before, the type 2 alveolar cells, which makes surfactant. And so there's decreased surfactant in the lung. And surfactant also induces the p53 pathway, causing further increase in PI1. So this is one of the few of the role factors that emphasize the role of fibrinolysis. In another picture, I show it here. On the left side is the hyaline membrane in the alveolus. If there's a high PI1, it will block urokinase from lysing the hyaline membrane. In the middle, if there's insufficient PI1, there's hemorrhage because of the action of UPA. And finally, on the right side, as I mentioned, excess PI1 will cause pulmonary fibrosis. So far I've discussed the different factors, severe of the disease, use of anticoagulants, the prolonged PTT, the lupus anticoagulant, and the low factor 12. But there's something else which we must not forget, and that is the comorbid conditions. If the patient has cardiovascular disease, cancer, age, older age, hypertension, diabetes, obesity, and all these will not only make the patient more susceptible to COVID-19 infection, but it will make the infection worse. And please note, all these conditions, a high PI1 level is present in each and every one of these conditions. So I just cannot overemphasize the importance of high PI1 in this disease. If you look in a very large series showing which one of these comorbidities is common, is the pre-existing cardiovascular disease. So to show you some pictures how the heart is involved in COVID-19, here are some electron microscopy showing where the red arrow shows the classic appearance of the virus with the spikes. This is taken from a biopsy of the heart. The other thing I want to show you is the kidney. The kidney is involved as much as close to a quarter of the patients, even more in severe cases, 60% of COVID patients. And this particular report is the result of autopsy findings in 26 patients. And we can see in the kidney, there's a combination of microthrombi, at which I'll show you the picture, presence of red cell aggregation and direct virus in the kidneys. So let me show you the picture. And here in this picture, if you look at the bottom left, you can see there's a presence where the arrow points to a microthrombus within the glomerulus. And then on the upper left, you can see a blood vessel here, which is a peritubular vessel blocked by aggregated red cells. And on the right side, again, you see the direct presence on the EM of the virus in the kidney. Time to turn to other pathways where the hypercoagulability can happen. And this is the complement pathway, familiar to you, the 3 pathways, but I'll just talk about the mannose pathway on the right-hand side. And the marker is in the pathogenic surface, results in activation of CD4, which then carries on the C3 pathway all the way to the formation of C5b, AKA membrane attack complex. This is the way in which the complement system will attack the target cells, and this membrane attack complex damage the cells and cause holes in the membrane. So what happened in COVID-19? I think I just showed some pictures. These are autopsy specimens. This is from the lung, and it shows on the upper left the presence of immune peroxidase stain positive for C4D, immunofluorescence positive for C4D, and the COVID spike protein is also present. Another picture showing the membrane attack complex, or C5b, immunoperoxidase, spike protein in red color, and immunofluorescence. When you put the two together, they co-localize. So the membrane attack proteins and the spike proteins all happen co-localize in this is the lining of blood vessels in the lung. Another nice picture showing in a patient who had right foot being cold with a mottled appearance. And so a biopsy was done. And on the upper left, the picture shows a thrombus in a small artery in that biopsy. The same specimen studied for C5b, immunoperoxidase positive of that vessel. And C4D is also positive. So you would say, oh yes, of course, because that artery is thrombosed. But then in the same patient, a biopsy is done somewhere else in the deltoid region where the skin appears normal, and yet there is the membrane attack complex, C5b. This illustrates the extensiveness of the involvement of the complement system in COVID-19. And there are more things, and I just want to show you, I've discussed the coagulation, the complement activation, but there's one more element. The neutrophils are also involved. Now, in the neutrophils, in an infection, they extrude extracellular traps shown in red color. And they are, the aim of these traps are to trap bacteria so the neutrophils can kill these bacteria. But it's also seen active in COVID-19. So now I have to turn to platelets. This is the work done on SARS, but it's similar with SARS-CoV-2, which is COVID-19. And this work was done when there was a SARS epidemic. And the right side shows immunofluorescence of that protein in green color. Over here in the cell line, here is in megakaryocytes, and here's the CD34 cells. Patients respond to these SARS protein infection by increasing thrombopoietin. So as a result, bone marrow makes more megakaryocytes and make more platelets. There's a high platelet turnover. Now with a high platelet turnover, we're seeing more young platelets in the circulation. At the same time, many of the platelets are in contact with thrombin in the body. These two kinds of platelets in the circulation, the young platelets and the coated platelets, are much more procoagulant than the other kinds of platelets and the rest of the platelets. So if this is high in COVID-19, is another factor for hypercoagulability. If the bone marrow lags behind or the consumption of platelets is high, we see thrombocytopenia that is associated with poor prognosis. There's something else related to platelets that concerns people looking after COVID-19 patients. The first is ITP, idiopathic thrombocytopenic purpura. And according to Dr. Buzel, an expert on chronic ITP, he indicated there's no change when COVID in a patients that had chronic ITP and then get infected. One other platelet disease is the TTP, thrombotic thrombocytopenia purpura, where there are multiple platelet thrombi throughout the body. And, but this is different from the microthrombi in COVID. So in TTP, there's a contraindications to giving platelets, but not so in the case of COVID-19. There's no contraindications if the patient requires platelet transfusion. There are other things I would just briefly talk about. If the patient has sickle cell and picked up COVID-19 and so happens to develop chest disease, acute chest syndrome, you have to distinguish whether this is acute chest syndrome seen in sickle cell crisis or this is pulmonary symptoms from COVID-19. I already mentioned that ITP is not worse, but I'd like to say just one word about red cell aggregation. In circulating blood, red cells are not aggregated, but when you see a patient at very high fibrinogen, they could aggregate and block blood vessels, as I just showed you in the peritubular vessel in the kidney. It's been shown years ago, the viscosity of the blood is related to the level of fibrinogen. And this because blood is a non-Newtonian fluid. And so if we are seeing, like in COVID-19, fibrinogen level commonly is double this high level, 270, 500, and so on. So you can see the viscosity will be sky high up there. And that is due to both the fibrinogen and, more importantly, red cell aggregation. Then we had to look at the endothelial damage, which I've been talking about present in COVID-19. But we don't always remember the endothelium is a large surface in the body, as much as 360 to 400 square meter, if you calculate the amount of endothelium. But not all endothelium are the same. It is very heterogeneous in structure, in function, in time, in space, in health, and in disease. And certainly that heterogeneity can explain why some organs get more damage than the rest, even though the damage is due to endothelium. So we have to summarize now. Again, this picture showing one, the spike protein binding to ACE2, leading to increased angiotensin 2, which cause high pi1, high fibrinolysis, and hypercoagulable state. 3, angiotensin 2 also binds the receptor in the lung, causing lung injury and acute inflammation. 4, 5, endothelial activation, leading to thrombin formation, hypercoagulable state. 6, activated platelets and neutrophil involvement, complement activation, lupus endocrine. And I had not mentioned if the patient had concurrent to the COVID infection has bacterial sepsis, that will also cause hypercoagulable state. And don't forget the comorbid conditions. And finally, the microthrombi from and the red cell aggregation. So now I have to turn with the last few minutes to the guidelines that had been given for this disease. First on anticoagulation, either a prophy dose of low molecular heparin shown above, 40 milligrams daily or twice a day, or unfractionated heparin, 500 units. And if the patient is obese, it's a higher amount is given, 750. If therapeutic dose is chosen, it's given with unfractionated heparin And if low molecular heparin is used, it had to be adjusted for renal function and other drug interactions. Don't have time to go into that. That's just a website showing the different drug interactions. Likewise, if the patient is getting antiplatelet drugs for other indications, the antivirals that the patients get may interfere with the CYP3A4 system. And so the antiplatelet drug need to be switched to one that does not depend on CYP3A4. As I mentioned earlier, there's no contraindications for red cell transfusion, platelet transfusion, or plasma. Again, I cannot overemphasize more that the drug interactions, patients may be getting different kinds of medications, including those with experimental drugs. And there are many drug interactions in that. And then avoid, if possible, intravenous drugs if alternate routes are available. This is to minimize the exposure of healthcare workers to COVID-19. And then the long term, after the patient has recovered, at least 3 months of anticoagulation. The DOACs can be used, the direct oral anticoagulants can be used, except when it's contraindicated, like when patients have mechanical heart valves or the patient has acute phospholipid syndrome. One of the interesting things is many guidelines I read, the experts recommend one of the new DOACs that is long-acting called betrixaban. Little do they know in practice, we do not have, even though approved by FDA, betrixaban because the drug companies stopped making them. So there are many, leave us with many unanswered questions. Are the platelets functional? I mentioned that. If there's a widespread endothelial damage, shouldn't we see more the DIC-like picture? Or should we see bleeding? Why is bleeding, generalized bleeding, rare? What are the long-term sequelae? Impaired lung function, renal function, cardiovascular function? How long are they going to be coagulable, hypercoagulable? And why don't we see the same degree of hypercoagulability in SARS and in MERS, since many of the mechanisms are similar in those other diseases? There are a lot of therapies not tried. I had emphasized quite a bit of the role of PI1 in here. There are inhibitors of PI1, they had not been tried. And I understand the latter one in here, the TM5614, is currently in phase 2 clinical trial, but not in COVID-19. Inhibitors of platelet function doesn't work. TPA have been tried on a limited number of patients by several investigators in COVID-19 with mixed results. But then one had to take note that in the lung, in the healthy person, it's not TPA, the expression is UPA. And we don't have urokinase to use because again, the drug manufacturer of urokinases stopped making it a few years back. And you must have other unanswered questions. So in conclusion, we're dealing with new findings and new observations. We are seeing a hypercoagulable state, and that is proportional to the severity of the disease. There are multiple factors: severity of the disease, severity of acute inflammation, the lack of fibrinolysis, medications, and comorbid conditions. And our guidelines that we are seeing are based on the conventional wisdom, but the wisdom is based on other diseases. It had to be modified with new observations we see in COVID-19 and needs regular updating. Well, this tiger must be tamed. Thank you.
Thank you very much, Hau. Beautiful talk. And you gave a talk to a full house, even though you can't see it. There was a full cast of characters listening to your talk. So we really appreciate the effort you put in. We do have a few minutes for questions, and there were a few comments One being, if you could comment on the role of bradykinin in endothelial damage.
Yes, the bradykinin system is activated because of the acute inflammation. Any drugs interfering with this system had not been tried. What I didn't mention is the activation of that system also activates the fibrinolytic system and increase the TPA. But then we had such a high pyruvate level, so the resultant fibrinolytic activity is still hypofibrinolysis.
Great. Another comment relates to severely ill patients who develop hypotension and require infusion of pressors. In some cases, angiotensin II is used to support blood pressure. In view of some of the things you just discussed, what do you think about using that in this context, obviously in a COVID patient?
Obviously, as I mentioned, the high angiotensin level can be very harmful. So if that is used as a inotropic agent in patients with hypotension, it had to be used with care, and excessive use of angiotensin II will be counterproductive.
And we also have a question regarding lupus anticoagulant in patients with mild cases, those that aren't hospitalized. Any sense of what the implications are there?
The implication again is the severity of the lupus anticoagulant test. If it's very high level, then as I mentioned, it is prothrombotic. A mild level, I don't think will contribute much to it except confusion when you read the coagulation profile.
Okay. And we have a question from Dr. Ma. Is VTE prophylaxis recommended after discharge in COVID patients, given the increased risk for weeks to months? And how long should COVID patients with confirmed VTE receive anticoagulation?
As I said, the duration is unknown because if I'm correct, the longest COVID recovered patient is still less than 6 months. So I think that picture needs to be evaluated at the end. Let's say you give DOAX for 3 months. At the end of that, you got to reevaluate. Again, one of the criteria is just like we do usually for thrombosis, and is look at the D dimer value, and that will be very helpful again here.
Okay, and we have another question from Mark Walsh, who said that we found that all patients have fibrinolytic shutdown. Those patients who have died had some fibrinolysis, but not great. Does this mean that the threshold for defining fibrinolysis in COVID is much different, and that we should be concerned if we see fibrinolysis on the TEG as a marker for severity?
There are two things two questions there, and they're both excellent questions. Number one, how we define fibrinolysis has to be interpreted a little bit different from we see in fibrinolysis in other conditions, such as in major trauma, because of the several things that I already mentioned, the high level of fibrinogen and the high level of Pi1. The second question is many of the conventional test turnaround time is pretty long. And so the recent tendency for many emergency room doctors and ICU doctors is use a quicker turnaround time, and then it's to use elastography to do it, which can tell a lot of information, as I try to demonstrate with ROTAM or with TEG.
And Carlin made a comment to the entire group, Carlin Martin, that there are several studies getting started at other institutions to look at post-discharge VTE incidents and whether extended prophylaxis is beneficial. So as you said, Hau, more data is coming.
That is correct, yeah.
All right, well, I think we've come to the close of the hour of an excellent grand rounds, and I appreciate everybody participating, and particularly you, Hau, for putting this together.
Thank you.
Everybody have a good holiday weekend.